we are discussing about the ophthalmic anesthesia. So we will give you some highlights and some difficulties faced by the ophthalmologists during the surgery under anesthesia. So we are trying to make it more streamlined for ophthalmologists. So the first talk is by Dr. Shalini Subramanya. She is a dear junior from All India Institute of Medical Sciences. So she is working in Narayan Nethralaya as a consultant for last so many years. So she will talk about the pre-operative management investigation and how to do it right. Over to Shalini.
Thank you, ma'am. Okay. Good morning. Greetings from Narayan Nethralaya and the Garden City of Bangalore. And for those who have so graciously come to our morning session on ophthalmic anesthesia, I promise to make my talk on pre-surgery optimization of pre-existing disease for eye surgery, short, crisp, and practice-oriented. For the rest of the talk, I will deal with adult patients posted for elective eye surgery under regional anesthesia. The consensus, guidelines, and evidence is quite robust with respect to cataract surgery, but I will also touch upon other ophthalmic specialties like vitreoretinal, glaucoma, orbitoplasty, squint, as and when they are different or pertinent or available. Now, when we talk about eye surgery, there are certain merits as well as challenges involved in it. The advantages are that they do not cause too much of physiological stress, no major fluid shifts, no major blood loss, and amenable to being done under regional techniques as a day case surgery, so that there is minimum interruption of their daily routine with respect to diet or drugs. But it also has certain challenges in that the patients may be elderly, frail, multiple coexisting disease, polypharmacy, and often they are done in ambulatory surgery centers or standalone centers with limited access to medical or cardiac critical care. And pre-surgery optimization means stabilizing the perioperative or surgical risk, that is with an aim to reduce the morbidity and mortality due to that surgery in that patient. And these perioperative and this pre-operative optimization or targets may be slightly different from population or primary care targets, in which the aim is to reduce long-term morbidity. And these guidelines, numbers, targets have been given by various anesthesia as well as ophthalmology organizations. We will look at them in the Indian context also. Now, the most common disease that probably existent in these patients presenting for eye surgery is hypertension. It is also the most common reason for postponement or cancellation on the morning of surgery. Now, Perioperative Quality Initiative, which is a multidisciplinary international organization that studies and releases consensus statements on issues in perioperative medicine, states that no patient should be cancelled just for a BP value. So is there a cutoff or threshold value in the preoperative period or on the morning of surgery below which it is safe and above which it is risky to go ahead with elective surgery? Well, there is no absolute number, but literature does give an arbitrary number, and this number is 180 by 110 millimeter mercury. Once again, because the number is arbitrary, I will not repeat this number again and again, and just call it a severely elevated BP. And any BP above this is called that patient is said to have a hypertensive crisis. Now, this hypertensive crisis or this high BP, severely elevated BP, is associated with signs of acute target organ damage like acute pulmonary edema, dyspnea, inability to lie supine, volume overload, acute kidney injury, or acute encephalopathy, acute confusion. Then elective surgery is a definite no-no, and the patient has to be immediately referred to medical care for intravenous antihypertensives and invasive monitoring. On the other hand, the same severely elevated BP, if it is not associated with any such signs of acute target organ damage, then that is called hypertensive urgency, which still has the risk of becoming a hypertensive emergency if not treated. Now, if simple remedial measures like giving anxiolysis or giving the missed dose of antihypertensive, which they may have missed due to any kind of NPO orders, can bring it to safe level, then we can go ahead with surgery on that day. Otherwise, it is better to defer and refer them to their primary care physician, because generally hypertensive urgency states gives us around 24 to 48 hours time to lower the BP. However, acute lowering of BP just to reach one target level is neither safe nor recommended. One word I would like to add, that certain surgeries like glaucoma surgery or lacrimal or orbital surgery or DCR, hypertension is sometimes perceived as a risk of intraoperative or postoperative bleeding. And in these patients, when it is better to impress upon them at the OPD level itself, either ophthalmology OPD or the PSC clinic, about the importance of home monitoring of BP to avoid undue delay or cancellation or confusion on the morning of surgery. The next common coexisting disease is diabetes, which is a state of chronic hyperglycemia. And hyperglycemia, we know from other literature related to cardiac or non-cardiac surgery that it has a potential risk of increased postoperative inflammation, delayed wound healing, as well as the surgical site infection, which in ophthalmology would mean the dreaded endophthalmitis. However, there is no definitive evidence linking hyperglycemia with any of these complications in eye surgery. Still, nevertheless, majority of ophthalmologists and anesthesiologists would like to have stable glycemic levels in the perioperative period. Once again, are there any magic numbers? Let's see. So if a diabetic, best is to identify optimization at the clinic level itself, either at the ophthalmology OPD or at the PAC clinic. If a diabetic patient comes and he has glycemic records, if he has done any kind of monitoring of fasting and postprandial sugar levels, or nowadays many of them come with continuous glucose monitoring patches, you can have a look at their app, and if the levels are consistently below 200 mg%, it's safe and good to go ahead with scheduling them for elective surgery. Or if they have a recent HbA1c which gives the mean glucose level over 3 months, and that is less than 8.5%, once again it's good to post them for elective surgery. High HbA1c levels, we never wait for them to normalize. However, if it is identified at this preoperative level, they are referred to the diabetologist who alters the anti-diabetic drugs, and once the fasting and postprandial are less than 200, we can go ahead with elective surgery. So if this exercise has been done religiously, then it is easy to make decisions on the morning of surgery. So what are the safe sugar levels on the morning of surgery? Now, definitely if it is associated with any kind of metabolic crisis, which may occur at levels above 250 mg%, then we would probably not like to go ahead with surgery. The safe level on the morning of surgery is given by various guidelines, including anesthesia and ophthalmology guidelines, to be 200 mg%. Some say 180 mg, some 200, some refer to as 12 millimoles per liter, which translate to 216 mg%. So we can make a general rule 200 plus or minus 10% if the preoperative exercise has been done properly. And this is the preprandial or fasting level. What about cataract surgery patients who often have their breakfast, their anti-diabetic drug, and then come for surgery? In them, if once again the preoperative stabilization has already been assessed, we could give them the benefit of doubt on that day, assuming that the increase in sugar level is probably due to acute stress or missing any of their anti-diabetic medication, in which case, once again, we can allow a 10% margin for them. Another note is that diabetic patients, it's best to post them early in the list to avoid prolonged starvation, dehydration, or hypoglycemia. Now, for cataract surgery, the perceived cardiac risk is less than 1%. In fact, it is only around 0.01%. And so patients who have chronic coronary artery disease, who do not have any new onset chest pain, dyspnea, or peripheral edema, and who can lie supine for the expected duration of surgery, it's good to go ahead with cataract surgery. Cataract surgery can also be scheduled 4 to 6 weeks after acute coronary syndrome, or even 30 days after percutaneous intervention. This is specific for cataract surgery, 30 days after percutaneous intervention with stenting, provided we do not stop the dual antiplatelet drug. Now coming to this eternal question of how to manage antithrombotic drugs in the perioperative period for patients presenting for eye surgery, it is a constant balance between the yin of the risk of surgical bleeding and the yang of the risk of systemic thromboembolism. But with better understanding of thromboembolic risk and improvement in surgical instrumentation, we have with every passing year, with more evidence coming up, we have more consensus and less controversies. And if we had to search for a formula to find the zone of safety, it has two variables. One is the bleeding risk and the other is the thrombotic risk. Now, the risk of surgical bleeding in eye surgery depends. Guidelines that refer to eye surgery as just one line in their entire document may not be exactly pertinent, because even within the various eye specialties, depending upon the complexity of the ocular pathology, invasiveness of surgery, type of anesthesia, and other coexisting diseases like renal or liver impairment and hypertension, the surgical bleeding risk may differ. And for thrombotic risk, there are various scores. The commonest is the CHAD score for atrial fibrillation, and there are other scores which cardiologists use for coronary artery stented patients. Now, before we go to the actual clinical scenarios, let us see which are these antithrombotic drugs. They can be either antiplatelet drugs or anticoagulants. coagulant drugs. Antiplatelet drugs are either aspirin or thienopyridine analogs, which are clopidogrel, ticagrelor, or prasugrel. They are all inhibitors of platelet aggregation, and they are used for prevention of stent thrombosis, or secondary prevention of stroke, or primary or secondary prevention of myocardial infarction or peripheral arterial disease. And if both aspirin and clopidogrel or ticagrelor are used in conjunction, then that is called dual antiplatelet therapy, which is particularly important in preventing stent thrombosis in the first 6 months after percutaneous intervention. With regards to anticoagulants, they inhibit clot formation, and the traditional one is warfarin or coumarin, which is acetone, which is a vitamin K antagonist. This still has an indication in the area of mechanical valve disease and valvular-related atrial fibrillation. All patients on warfarin will have a target INR which their cardiologist would have informed them about, and we need to be aware of this therapeutic INR for that patient for that condition. And, but in several other clinical conditions, warfarin has been superseded and replaced by direct oral anticoagulants or novel oral anticoagulants, of which there are 2 types, thrombin inhibitors and apixaban. So these are used in non-valvular AF and prevention and treatment of venous thromboembolism. So once again, we have to balance the thrombotic versus bleeding risk. Now, it becomes very simple. If the bleeding risk of that eye surgery, which are those eye surgeries, I will tell in the next slide.
Dr. Shalini, your time is up.
Just a minute, ma'am, this is the last slide. If it is low, then we go ahead with anticoagulant and antiplatelet therapy. If the bleeding risk is high, then and the thrombotic risk is low, 80% of the time we will be able to discontinue the drug if the primary condition for which the drug was started has now been stabilized. There is a very small cohort of patients in whom the bleeding risk is high and the thromboembolic risk is high, in which the decision to go ahead, we can take any of the 3 decisions. One is postpone the surgery until it is safe, or second, because surgical bleeding is still a gray area with many evidence suggesting that it is not true, then we can re-explore the risk by optimizing other factors which may increase bleeding, like using subtenons anesthesia, or using a 25 or 27 gauge vitrectomy, or controlling BP well. And there is a very, very small section of patients who might require bridging therapy. Now, cataract, of course, the consensus is clear that it is a low risk of bleeding. Peribulbar anesthesia also causes only non-site-threatening hemorrhage, that is lid ecchymosis or subconjunctival hemorrhage. High-risk surgery, where the evidence is not robust, includes retinal diseases with diabetic vasculopathy, glaucoma surgery, and DCR. So in conclusion, I will say please be aware of the perioperative goals and the recent literature, and it's better to have written guidelines for your institute after taking into concern all the specialties, and I hope this working knowledge was useful to you, and use this knowledge to counsel the patient about primary targets rather than cancel the case on that day. Thank you so much.
Thank you, Dr. Shalini. We will discuss in the end of this session about the queries. I must think that there will be too many queries also. Okay. Please put the CV of the second person. So now I call Dr. Sumanshri. The topic of Dr. Sumanshri is preoperative and intraoperative anxiety management. I am sure we all have some relatives who must have undergone any type of ophthalmic surgery, and we know the importance of the anxiety management for our near dear and for our patients also. So over to Dr. Sumanshri.
Namaste to all. I bring warm greetings from Netradhama Super Speciality Eye Hospital. I'm going to cover my talk in a brief outline being introduction, causes of anxiety, effects of anxiety, anxiety assessment, management, both non-pharmacological and pharmacological, DexMed, the magic potion, and the take-home message. What is anxiety? An unpleasant sensation associated with fear, tension, and nervousness, both in adults and children. Preoperative anxiety is secondary to a diagnosis of a disease, hospitalization, and a planned surgery. Obviously, intra-op anxiety is only in regional anesthesia, local anesthesia, not for general anesthesia, as the anesthetist takes care of all of that. The prevalence is around 48%. Can you imagine that? What are some of the causes? Specific fears of surgery like operation, getting blind, claustrophobia, complications during operation, my vision not recovering completely, waiting time for surgery, operation failing, keeping still during the operation, especially under regional anesthesia, nudeness, perioperative pain, and the results or outcomes of surgery. What are some specific fears about anesthesia? Anesthesiologist error, after all we are humans, waking up during surgery, awareness, or not waking up at all, death, personality changes, loss of control, postoperative nausea, vomiting, a fatigue or drowsiness, and just perioperative pain. Now, specific to eye surgery, they are scared about some visual sensations during surgery like cataract. Of course, women and hypochondriacs. Bilateral eye surgery, significant predictor of pain is the anxiety levels resulting in stress. Also, fear of moving your head or eye during surgery, coughing, or just being uncooperative to your anesthetist or surgeon too. And finally, being injected by different practitioners for intravitreal injections, it is correlated to preoperative anxiety and hence should be avoided. So what are the effects of this anxiety? Activation of your autonomic nervous system called as a stress response. Rise in heart rate, BP, could lead to acute left ventricular failure, acute pulmonary edema, or increased myocardial workload and acute MI. You all know about the white coat hypertension. It can have panic attack, breath holding, hypoxemia, and seizures too. And the dreaded cancellation on the day of surgery, increased anesthetic requirement, delayed awakening, post-op pain, a longer hospital stay, dissatisfaction, and a delayed wound healing. So how do we assess this? We have the Amsterdam Preoperative Anxiety and Information Scale for adults, which results in the global anxiety score, and accordingly, we can give either information or send them back to the surgical team or anesthesia team. This is how we do it in Netradama. This scoring is incorporated in something known as the preoperative self-questionnaire. We also have an immediate pre-op self-declaration form for all symptoms on the morning of surgery, whether it is ophthalmic or general. For children, we have the MyPass, the Modified Yale Perioperative Anxiety Scale, or the Pediatric Anesthesia Behavior Scale, which correlates with the emergence delirium after GA. We also have the stakes score. Now let us see what we can do about this. Very important during pre-anesthetic evaluation is counseling, personalized empathetic communication, judicious PAC, and we also have the non-pharmacological and the pharmacological methods. This is how we have a pre- and post-operative instructions for eye surgery at Netradama. What about starving? Rather, nil oral status of your patient. What are the pros and cons? Of course, if you do not starve them, what happens is the risk of aspiration, and especially deep sedation and GA, crisis requiring resuscitation, or certain logistical situations. But what are against starving? Because severe starving can cause dehydration, hypovolemia, omission of medication, enhance the pain and patient experience. So there's lack of consensus. As of now, no fasting for uncomplicated cataracts. And it can also cause anxiety, irritability, headache, resulting in hypotension and catabolism and insulin resistance. Now let us see the non-pharmacological methods. You have cognitive behavioral therapy, you have counseling, you have massages, aromatherapy, video counseling, music therapy, acupuncture, spiritual meditation, hypnosis therapy, and all we need is verbal counseling, like verbal anesthesia as we call it. Even in children, nowadays, virtual reality is being used apart from dolls and mobiles. There's a very important thing known as verbal reassurance, explaining to the patient, informing them about the protocols. We call it as Kalma Sutra, calm the patient down and clarify all the doubts. There's a new concept known as anticipatory reassurance. For every step in the cataract surgery, there is an anticipatory question and an answer. We can make our counselors learn these questions and respond in a standard operating protocol for every doubt a patient may have. It's an amazing tool that we can all use. What about the non-verbal comforting, like hand-holding by nurse, playing music in the OR, not only for the patient, even for the surgical and anesthesia team? Now let us go to pharmacological methods called procedural sedation. It alleviates anxiety. What is an ideal sedative? Reduces stress, raises the pain threshold, improves cooperation, striking a balance between reduction of pain and without losing consciousness and awareness. It's known as conscious sedation. And it should not disturb patient's ability to communicate. You're all familiar with the oral alprazolam that is being used preoperatively. Now we also have intranasal, dexmed and midazolam, and finally the intravenous techniques. Let us look what all we have. We have the alpha-2 adrenoceptor agonists. Dexmed is number 1, both intranasal, intravenous. The other is clonidine. We have various benzodiazepines, opioids like fentanyl, remifentanil, ketamine, propofol, and now the new kid on the block is melatonin and some gabapentinoids too. So you're all familiar with the oral tablet Restil or Angsit that we all give. It also helps the surgeon. In fact, there's a study which says that before phaco, it leads to lesser PCR, shorter OT time, and prevents repetitive surgery, lesser PCO. Essentially, even the ophthalmologist is happy with this. But of course, due to the adverse effects of delirium and benzodiazepines, its use has reduced. Let's see our magic drug, which I'm so excited about. We have done a lot of research and studies on Dexmed. It produces sedation, but arousable, and something known as the biomimetic sleep, ideal for daycare. And it does not have any psychomotor side effects. So it has a psychomotor sparing benefit. And that is why Dexmed is being promoted. It can be used intranasally, 0.5 mics per kg. In fact, we had a publication. Also, there is Dr. Chandrakumar has a single or intermittent bolus, which is also very useful in cataract surgery. And this is how we spray the nasal Dexmed. It's very easy to use. We also have some experience in giving it intravenous in retinal surgeries, and we have found out that 0.25 mics per kg over 10 minutes loading dose and maintenance of 0.25 mics per kg per hour titrated is very useful even in beta block patients, as long as there's continuous cardiac monitoring of these patients, which is very critical to the success of Dexmed. Nowadays, we've also started using intranasal Dexmed for pre-medication before pediatric surgeries. We give 1 to 2 micrograms per kg, and it is very, very useful. The onset is in 25 minutes, and the duration is about 85 minutes. Finally, the take-home message for all of you ophthalmologists is a thorough pre-anesthetic evaluation is mandatory, including your anxiety assessment score. Secondly, personalized communication with the 2 types of reassurance that I referred to, verbal and anticipatory reassurance. Customized pre-medication, both for GA and regional. Monitored anesthesia care, which we call as MAC, with titrated procedural sedation to reduce anxiety, facilitate a management of perioperative hypertension and tachycardia. And lastly, a perioperative anxiolysis, sedation, and analgesia definitely improves the surgical outcomes, both in adults and children, in general anesthesia, local and regional anesthesia. I take this opportunity to thank All India Ophthalmic Society and also the new All India Ophthalmic Anesthesiologist Society for inviting me and letting me share our knowledge with all of you. Thank you very much once again, Dr. Renu.
Thank you, Dr. Suman. I hope that patients will be less anxious and more happy and coming back with their relatives also to get operation. So the next topic is regional anesthesia for eye surgery. What is newer and safer? I know that regional anesthesia is more done by the ophthalmologist than the anesthetist. But as an anesthetist, we have more knowledge about the drugs and other newer procedures. So that's why this topic is for an anesthesiologist who is working in a tertiary ophthalmic anesthesia center, that is RP Center AIMS, Dr. Arshad Over to you.
A very good morning to all.
So,
मुझे भी change करना है. Good morning all. Myself Dr. Arshad Ayub. I am from AIMS New Delhi. I am here to talk about regional anesthesia in ophthalmology. What's new we are planning to do and what's new we are doing now. So initially when I joined in the RP center around 7 years back, my perception was ophthalmology is all about the cataracts, which is a short procedure, which is ambulatory, which has got minimal pain and can be done under topical anesthesia or the peribulbar anesthesia. Then I got a shock that no, this is not. It is for the neurofibroma for orbitotomy, which is orbital tumors. This is for DCR. This is for syndromic for the major repair, for the burn trauma of the patient, for the graft from the post-auricular graft or the intra-auricular graft. And these cannot be done without with a simple peribulbar block or a topical block. So what was the solution to us? The solution was we started using and trying to use the ultrasound guided regional blocks. For those who are the ophthalmologists here, this might be a new thing to you. So I would like to inform in a very brief about what is ultrasound and how do we use it. So ultrasound is basically consists of a transducer which have piezoelectric crystals, which when stimulated gets vibrated and produces the sound waves. These sound waves go and hit our target structure, and then these sound waves are reflected back to the transducers, and then these transducers project these images on a screen to get an image. For example, if we are scanning the kidney, we are putting a transducer and we are scanning the kidney. So sound waves are emerging from the probe and getting reflected back to the probe from the kidney, and we are getting an image. So ultrasound waves are there, then they are reflected sound waves, and then these reflected sound waves are perceived by the probe to prepare and process an image. So there are two important things in that. Number one, transducer, and number two, the tissue, and we also call in terms of tissue ecogenicity. So what is the ecogenicity of the tissue? So there are three types of transducers. We have linear and we have curvilinear probes. In linear, we have small probes and we have a larger probe. And in a curvilinear probe, we have a high frequency probe which has increased penetration and can be used for the ocular ultrasound. For ecogenicity of the tissue, it depends upon tissue to tissue. For example, the bone would look like a hyperechoic structure. A white line, a continuous hyperechoic structure would be a bone through which no sound wave can pass. So this is what it will look like. Then there is the muscle. Then there is a vessel which would look anechoic, that is completely black. And the muscle has got fibrous strands and the collagen, and then they would look like something like this. And then we have the fascia, which encloses and it looks hyperechoic, but the sound wave may pass through it. So remember, the bone is a completely hyperechoic structure through which no sound wave can pass. Now, when we know this thing, there are two types of needling approaches. One via called in-plane approach, one via called out-of-plane approach. When we go out of the plane, we can only see a point of intersection of the needle which is coming on the path of the sound waves. So you might be able to look only indentations or a point of the needle. Or if you're going in-plane approach, then you will be able to see the whole length of that. We will come across with these type of techniques soon in next presentation. So after this, what are the nerve blocks that we are going to discuss here? We are going to discuss infraorbital, supraorbital, mental nerve block for the lip grafts, and zygomatic-temporal for the lateral part of the eye. And sometimes we have to take graph from the posterior part of the ear, and which includes lesser occipital or the greater auricular nerves, which are the part of the cervical plexus for the grafting. So let's jump to the reason and start what we are doing and how we are doing. To understand this, we have to understand the anatomy. We have to understand how to scan, how to know what does the after scanning it will look like, and how to give the injections. So we'll be covering all this part on these three parts. Now let's jump onto the anatomy. That's what I was saying. I need to change. स्लाइड में नहीं है भाई, अलग से एक अलग पेज है. इंटरनेट नहीं भाई, ये ऑफलाइन है. स्क्रीन में डिस्प्ले होना चाहिए ना. So let's start with the anatomy. So we were talking about so we will talk about the supraorbital nerve, infraorbital nerve, zygomatic-temporal nerve, or the mental nerve. So supraorbital nerve, here you can say, is a branch of the ophthalmic division of the trigeminal nerve. This is the supraorbital nerve. Here the supraorbital nerve lies on the surface of a ridge or arises from a foramen called supraorbital foramen. Infraorbital nerve arises from a foramen called infraorbital foramen. Zygomatic-temporal nerve is on the lateral part of the temporal bone on the posterior orbital lip, just here. So this is the zygomatic-temporal nerve. Okay, so zygomatic-temporal nerve, if you want to block, we got to hit the posterior lip of the lateral orbital rim, and then there is a mental nerve. Mental nerve is arising from a mental foramen, which is just on the mandible. So how do we scan this? First of all, we keep a probe for supraorbital nerve. We keep the probe in a transverse view over the surface of on the forehead of the patient, and then we move down. As soon as when we keep it on the forehead of the patient, we should be able to see a bone. Bone should look like a hyperechoic white line. And as soon as we go down, we will see a breach in the continuity of that hyperechoic line. That breach should be sufficient enough to inform us that there is a lacuna in the bone there, and that lacuna is most probably because of the supraorbital foramen or the ridge. Similarly, with the infraorbital, we will start from the down below, and we will move the probe up. As soon as we will move the probe up, we should be able to see a breach in the continuity of the bone and should be able to see the infraorbital nerve. And for the zygomatic-temporal nerve, we will keep our probe on the zygomatic process, and this will look like a white hyperechoic line. As soon as we will move up, we should be able to see the loss of this continuity of the bone and only see a medial side of a part of the bone, and on the lateral part of it, we will deposit the drug and we will be able to block the zygomatic-temporal nerve. For the mental nerve, we will keep the probe on the mandibular, and then we will move up. As soon as we will move up, there will again a breach in the continuity of the bone, and we should be able to see the mental foramen. These nerves are very small and may or might not be visible to the naked eye or even in the ultrasound. Now, for the graft, we have two nerves. First is greater auricular nerve. It supplies the anterior part of the ear. If you want a graft from the anterior part of the ear, from the tragus, we have to block the greater auricular nerve. Then we have this nerve. This is the lesser occipital nerve. It supplies the posterior part of the ear. So if you want to take a posterior auricular graft, you have to block a lesser occipital nerve. But there is a simple thing to that. These both nerves are the part of the cervical plexus. So these are the cervical plexus. These are all three nerves are the part of the cervical plexus, and these are lying inside this muscle called sternocleidomastoid and lying on the surface of perivertebral prevertebral to muscles. So on the surface of the prevertebral muscles, we should be able to see the cervical plexus. These nerves are branch of the cervical plexus, and just on the lateral side of these two gate vessels called the carotid and IJV. So at the level where the carotid is dividing into two parts, at this part, we should be able to deposit the drug below sternocleidomastoid muscle above the prevertebral muscles, and we should be able to block the cervical plexus, and hence both greater auricular and the lesser occipital nerves. So once we know the anatomy, let's jump onto the blocks and the interesting part. It's not moving. Next slide.
Dr. Arshad, you have 2 minutes left.
Fine, ma'am. So coming on to the first supraorbital nerve, here we are keeping the probe on the forehead of the patient and going toward the supraorbital ridge. So what are we going to see? We are going to see a continuous white hyperechoic line, and when there will be a breach in the continuity of the hyperechoic line, that means this should be our supraorbital foramen. So this is the real-time scanning video of it. Here you can see we started with a hyperechoic line, and then we see a breach in the continuity of the line. So this is the supraorbital foramen. You can also see there are some vessels up there in the color mode. This shows that there are supraorbital artery and nerves up there. So we should always be safer to look out for the artery. This is one of the injection which is the out of plane, so you won't be able to see the whole length of it. You will be able to see some indentation and some drug deposition there. So after the supraorbital nerve, we have infraorbital nerve. We are again placing the probe below the infraorbital ridge, and then moving upwards, and you will see there is a continuous hyperechoic line, and then there is a breach in the continuity of the line. In this, you can also see a black anoic shadow. This is infraorbital artery. So if you can see in the scan, this is a white hyperechoic line, and then there is a breach. And in this, you can appreciate an artery there. This is infraorbital artery. The nerves are very small and difficult to visualize. This is the injection on it. If you can appreciate the indentation on the infraorbital foramen. So this is how we block the infraorbital nerve. Then there comes the mental nerve. Again, we are placing a probe on the mandible of the patient and then moving upwards. Again, a white hyperechoic line, and then there's a breach in the continuity of the continuity of the line. This proves that this is a mental foramen. So this is one of the videos of the scanning. This is white hyperechoic line, and you can appreciate that there is a breach in the continuity of it. So this is mental foramen. This is the injection video of it. You can see this some indentation happening there. I don't think it is very well much appreciated, but there's some drug deposition in the breach in the mental foramen. Next, we have zygomaticotemporal nerve. Zygomaticotemporal nerve, we put the probe on the zygomatic arch, which should look like a white hyperechoic line. And as soon as we to move up, the lateral part of the zygomatic arch or the white hyperechoic line will stop being visible, and only the medial part of it will be visible. So you will start with the zygomatic arch, keep the probe on the zygomatic arch, and then we will move up. keep the probe on the zygomatic arch and move up. So what you will see? You will see a white hyperechoic line, and then suddenly the white hyperechoic line will stop to coming, and you will see a just posterior orbital rim, and we will deposit the drug on the posterior orbital rim of this patient, and should be able to block the zygomatic temporal nerve. So this is a real-time in-plane approach where you should be able to see the complete length of it. So this is the orbital rim, and you can see a needle coming from the lateral side and depositing the drug on the lateral orbital rim. So this is how we block the zygomatic-temporal nerve. Lastly, it is the greater auricular and the posterior occipital nerve or the cervical plexus nerve. So we are putting the probe in a transverse view over the carotid, and then moving up to get to the point where we are able to see the division of the carotid artery into external and internal branch. So first of all, we have to look into this muscle, sternocleidomastoid.
Dr. Arshad, I think we will be not able to spare more time because there is another session after this.
Just 4 slides, ma'am. I just left with the 4 slides. So this is sternocleidomastoid. Then we have perivertebral muscles up there, and then we deposit the drug. You can see on this part of the carotid. This is the carotid dividing into 2 parts, and as we go laterally, we can see these 3 nerves. These are part of the cervical plexus. So what about the peribulbar? Is there any role of ultrasound in this? Ultrasound for peribulbar block is still in infancy, and it is not much recommended. Why? Because it presses the globe and decreases the space. Number 2, real-time injection is very,
I am sorry,
very
Dr.
difficult.
Arshad, it's 15 minutes, more than 15 minutes. So if we will have time, we will continue with your talk afterwards.
Just 2 slides left. This is the second last slide.
Okay.
But there's a session to follow you, right?
Just 2 slides left.
But there's still a session to follow you.
Shall I stop it now?
Yes.
Fine, thank you.
Thank you, Dr. Arshad. Now we call Dr. Tanveer. She will be discussing about the diagnosis, management, and prevention of systemic complication following eye surgery under regional anesthesia. Dr. Tanveer is working as a consultant, additional professor in PGI Chandigarh, and she has keen interest in ophthalmic anesthesia. So over to Dr. Tanveer.
Yeah, good morning, everybody. So I'll be talking about diagnosing, management, and prevention of systemic complications following eye surgery. Thankfully, we're very lucky that the incidence is less, but whenever they occur, they're really a nightmare for all the anesthesiologists and the ophthalmology team. So I just introduce, I am in the Advanced Eye Center in PGI. So because the objectives are threefold, so the slide is going to go along with it. Before I come to the exact systemic complications, we need to understand that we are using different techniques. We are using the topical, various regional blocks, the details of which have already been discussed. We're using eye drops and gels, all of them. And in the eye drops, we already know what are the most commonly used, so I will just be skipping all of them. Now, in the regional nerve blocks, we have the peribulbar, retrobulbar, subtenon, and facial. So there are different techniques, and the incidence of systemic complications with all of them is very different. Till now, we just have a combined incidence of around 0.4% with all the different techniques. Before knowing any complication, it's very important to know what you are injecting. So whatever is being given into the patient is the one which is going to decide what kind of a complication it could be. It could be because of the anesthetic agent. It could be because of the hyaluronidase. It could be because of the adrenaline which is being given. Now, one very talked about topic is phenylephrine, which is used during this kind of anesthesia. And whenever we have any complication, we are always worried about that, is it really a complication? What has happened? And what kind of a complication is? So just as I briefed in my previous slides, we could have a complication because of the local anesthetics, which we call as LAST. We could just have a simple anaphylaxis. Any drug, when given in the body, can cause anaphylaxis. And the most dreaded and the most common of all the complications are the cardiovascular complications, which can range from minor complications like just hypotension, tachycardia, arrhythmia, to as severe as on-table MI or a CHF. So just as I was saying that phenylephrine has always been talked about. So as you see the literature going back in the dates, you will find that in the previous years, it was very common that people were really thinking that phenylephrine is dangerous. But all further meta-analysis have proved that it is not a reason for concern. The 2.5% concentration leads to no clinically relevant change in any BP or heart rate. The changes which you see in the heart rate and BP with 10% are very short-lived, and generally, it's a temporary effect which is seen. But you have to be very careful in a certain subset of patients, especially diabetics who have a lot of autonomic neuropathy, and you have to be very careful in patients with pre-existing cardiac diseases. Any patient who has an increase in BP of 20 systolic and 10 diastolic, it increases the risk of stroke and MI to twofolds. So there's a certain subset of patient which needs to be identified where you might think that using higher concentrations of phenylephrine can be problematic. Then, as I already told you, that there are lots of hypersensitivity reactions which can always occur. So the hyaluronidase which you use should always be suspected, and you need to rule out infective etiologies because the clinical features always they overlap with each other. So coming to a definitive diagnosis is very, very difficult. So the only way, like it's a case report which I'm talking about, is that you can always do a intradermal sensitivity testing. And that is the best way which is going to actually tell you whether the patient is hypersensitive to a particular agent or not. The most important, the most dreaded is when you have the local anesthetic toxicity. We all know the mechanism of action of local anesthetic drugs, and we know about the spectrum of local anesthetic toxicities. Now, how do you identify that a patient has developed LAST? The patient can have a CNS complication, a CVS complication, which is one of the most common complications. So any patient, when complains of lightheadedness, dizziness, visual and auditory disturbances, muscle twitching, tremors, and on the worst, develops a non-stable seizure, should always be suspected of developing a local anesthetic toxicity. Because the local anesthetics affect the depolarization and repolarization in the conduction pathways of the heart. So we generally have arrhythmias, hypotension, hypertension, all kind of cardiovascular abnormalities can occur. The LAST always occurs in phases. So the phase 1 is always the CNS excitation phase, and the phase 2 is always the cardiovascular depression phase, and then ultimately it leads to cardiovascular collapse. So who raises the alarm? It's either the monitors, which we generally use. It's always advised that even if anybody is undergoing a MAC, that is a monitored anesthesia care, and especially if we can identify that the patient is a high-risk patient, it's always important to attach monitors. And the other important is self-report. Generally, whenever patients they start reporting certain systemic, they feel anxiety. When the anxiety level rises, there's a shoot in the blood pressures. They always complain of headache, chest pain, breathlessness. So these are the things which will raise the alarm. The most important thing which we all should know is how to manage LAST. Now, the first ever thing when you have a complication is you call for help. We are always called, even when the patient is undergoing something under local anesthesia. And if it is really severe, then our primary concern is just to support the ventilation and stop the seizures. Seizure management always remains the same. Position the patient, give midas, see the airway reflexes. And the most important management of LAST lies in the lipid emulsion therapy. The lipid emulsion should always be available in all OTs or all areas where we're using the local anesthetics, because LAST, although incidence is rare, is effectively managed if you have a lipid emulsion, intralipid which we say. So the dosing of the intralipid is 1.5 ml per kg bolus dose, and then you can infuse at a rate of 0.25 ml per kg per minute, and you have to keep watching the patient for regression of the symptoms, and you stop giving the intralipid once when you find that there has been recovery. The important differences when you're managing a patient with LAST from any other cardiovascular compromise is that you should not be giving any beta blockers, calcium channel blockers, or vasopressin in this subset of patients. And you can give low-dose epinephrine, like less than 1 mic per kg, a Meduron, and even bypass can be initiated when the patient is really severe. It is very, very important for everybody to understand that propofol is not a substitute for 20% intralipid. So do not replace propofol for intralipid. And the maximum recommended dose has been recently increased. Initially, we used 10 ml per kg, but now it is recommended you can go as high as 12 ml per kg. But generally, if you have used in patients, you will find that resolution of symptoms is usually achieved with doses half of the amount. Last, patients have to be very clinically monitored, and the neurological symptoms, if they are only present without any cardiovascular compromise, they generally improve in a time duration of 2 hours. And if there is cardiovascular compromise, then you have to observe for at least 6 hours, because the local anesthetic can redistribute from the various tissue depots. Now, the important question after having any systemic complication is, from the surgeon, is that, can I proceed further now the patient is stable? So that is the dilemma which is always there. So it's not that it's absolutely contraindicated. So it can be, we can accept to proceed with the planned surgery after treatment has been given with lipid, and you can additionally wait for 30 to 40 minutes after the resolution of the symptoms to assure that LAST does not recur. And it is very important to take such measures only in centers which have a backup, where you can admit the patient, follow up the patient, and you have a good support of the cardiology unit and the other medical facilities. And ideally, you can actually cancel the case and postpone it on another date. It is very important that whenever you have LAST, it should be reported to the national registries, and it is very important to mention whether intralipid has been used or not. The most important thing is prevention, because that is what is in our hands. So we should always learn to identify at-risk patients, patients with small muscle mass, which is very common in our Indian subcontinent, and patients at extremes of age. Both the pediatric age group and the geriatric age group are at increased risk of LAST. As I told you, patients with pre-existing heart diseases have to be always watched. The other risk factors is any patient with hepatic dysfunction, altered hepatic perfusion, low cardiac output states, even high cardiac output states cause risk. Reduced levels of plasma protein, pregnant patients, and patients who are on concomitant use of beta blockers, digoxin, calcium channel blockers, etc. Local anesthetic toxicity in children, it has to be understood, is even higher. It is a little difficult to recognize in children because they're generally under general anesthesia, which even makes the situation more difficult to be recognized. So do not think that any age group or any subset is free from LAST. Vigilance is of paramount importance. It is very important to remember that we do not have the classic representation of LAST in all cases. Half of the cases of LAST are atypical. There may not be any seizures. There could be only cardiovascular toxicity or a delayed onset of toxicity. So some other measures which you need to take whenever you're giving local anesthetics is that you have to adhere to the dosing guidelines, even if you're using a single bolus or a continuous infusion. You should use the lowest effective product concentration. You should use the smallest volume of local anesthetics, and we have just seen in the previous slide how ultrasound can be used. You should use ropivacaine instead of bupivacaine because the toxicity profile is less. You should use epinephrine to decrease the systemic absorption of local anesthetics. Aspiration, incremental aspiration is encouraged, and small doses should be injected. And you should always try and identify systemic injection via a test dose if possible. Avoid any vascular area because vascularity increases the absorption rate of the local anesthetics. Simulation-based learning sessions are to be encouraged so that if any untoward occurrence occur, we are not scattered, we are not hassled, we know the exact algorithm to be followed. Continuous surveillance is most important. There are lots of checklists which are available. I think questions will take up later. Thank you so much.
Thank you, Dr. Tanveer. Now, there is a lecture by Dr. Renu Sinha, who is me, how to improve efficiency and productivity in ophthalmic operating room. So, I am Dr. Renu Sinha. I am working as a professor in RP Center, AIMS. For last so many years, I am practicing ophthalmic anesthesia. So, coming from a anesthetist mouth and words that how to improve efficiency and productivity in ophthalmic operating room, because once we are running 4 OT under general anesthesia, we see that till 11 o'clock, in one OT, 5 cases were finished, but in another OT, only first case is going on. So, improving the efficiency is a multi-step process. So, it should be done with maintaining a high degree of safety and achieving excellent visual outcome. We all know that operating room is one of the most costly and important area in the hospital, and it contributes 2/3 of the total revenue of that hospital. But expenses are also high. It is 40% of all hospital expenses which are coming from OR. So any improvement in the utilization of OR will pay enormous dividend to the hospital authorities. So the key is collaboration between all the workers which are there in the OR. It needs good leadership, flawless organization structure, collaboration, and process entails decision-making like distribution of resources, direction of role and responsibilities, and frequent performance monitoring. So there are different metrics. The first case start time, total case time, case cancellation rate, staffing cost, and turnover times. So don't assume that everybody speaks the same language. Everybody understand the same language is important. Because for a nursing staff, one's definition of turnout time is period from when the one patient is out of the room until the next patient is brought into the room. But for the surgeon, period from end of one case until the incision is made in the next case. So starting time 7:30 a.m. doesn't refer to the patient coming to the OT. It is at the time when the surgeon puts the incision. Surgical beds are also very important in the hospital, in the pre-operating room, in the operating room, and in the PSU. So many times patient is not shifted because PSU is full. So what is to be done? Post-operative instruction can be given when the patient is on the chair if the surgery is done under topical or regional anesthesia to prevent the PSU bed. Then in many places, incorporating the efficient dilating protocol was done to reduce the time because many times mydriasis is not good, so the case is delayed. So they combined the dilating drops, tropicamide, NSAID, and proparacaine for the easier dilation of the eyes, and it can cut the cost of putting the repeated drops. Universal needs lead for monitors are also available, so it should be kept in the pre-operating room, operating room, and the PSU, so that once you are shifting the machine or monitor, you can shift only the machine or monitor, and you have the universal lead there. It is not needed in every patient to put the IV drip. You can put the IV line and put the saline lock, so that the patient can be shifted in the lesser time. Then smart OT equipments are also available. OT table with remote, with memory. So it is memory 1, 2, 3. If one surgeon is operating, just put one button and the table will be at that height and at that angle. Similarly for the operating chair also with the memory. For that surgeon, the thing is fixed, surgeon 1, surgeon 2, surgeon 3. So the operating chair will be at the same height for that person. In many places where they are running 2 OR, there is wireless doorbell put in the hallway. So timing of drape, the nurse will press the bell, so the other OT will know that how much time will take for that case. And when the IOL is placed exactly after 3 minutes, patient should be draped in the another OT to reduce the time. So the efficiency will depend upon whether it is individual practice, government hospital, or corporate hospital. If per day less than 10 cases are there, 1 OR is sufficient, 10 to 20, 2 ORs, and if you are doing more than 20 cases, then more than 2 OR may be needed, and accordingly staff will be there. The other thing is said that organization of the OT. Keep the layout of each OT same. so that the staff will develop a cognitive reflex, so the things will be less delayed. Sometimes on the right side the thing is there, sometimes the left side the machine is there, so it is difficult. Ensuring standard equipment at the same place in the OR along with the organization of the supply table is also important. If the supply table is organized in the same way again and again, so if the OT staff is taking leave, then the another staff can do the same stuff in the same time. So training of OR staff, pre-op nurse should be trained how to position the patient on the OR table. Scrub nurse should be trained how to prep and drape the patient for that type of surgery. And the assistant should know how to remove the drapes at the end of the case so that the lesser time will be taken. Post-op education should be started early in the clinic, so it will be not done in the OR. Nurse should just remind the post-op instruction, and these post-op instruction can be given also to them. One should aim that in the PSU, discharge should not be delayed by more than 15 minutes if patient is not getting any sedation. Anesthetic setup should also be good, because many a times for the children, a good competent anesthetist is needed to do the case early. So necessary drug and equipments, trained technicians, good quality machine and resuscitation cart, and evaluation of the patient before and after the surgery. Analyze the instrument requirement, because need of instrument will depend upon the type of surgery. So 8-minute cataract surgery will require more sets than the 12-minute surgery. 2 OR will require more sets than the 1 OR. And if there is delay because of the non-availability of the instrument, it's worth purchasing the another set. And all sets should be complete. So OR efficiency benchmark, this was the table which I got from one of the things. So there are 3 levels where the constraint is there: material sources and human resources. These 3 places one should work to reduce the OT time and to improve the efficiency. So it can be divided into 3 types. Patient entry into the OR till the incision, during the surgery, and end of the surgery to the patient out. These 3 areas will have different types of problems, so they should be tackled one by one separately. So bottleneck are mainly patient did not arrive on time, nurse do not have enough time to admit, waiting for the instrument, and PSU is full. So there are other issues also. If the patient is admitted in the ward nurse got involved in some other patient and patient was not shifted. HA is busy in the mobile and he doesn't know that the case is over. Lab reports didn't reach on time. Transport guy failed to deliver the equipments. Faulty OT machine. And nowadays in government institute, JSS and Ayushman Bharat, which takes more time because they need more clearance. And certainly because of the surgery type, AMG is not available before 10, or donor cornea will be assessed at 11 o'clock. So patient schedule should also be important. 1 patient in the OR and 1 patient ready to assess the mark. Predictable and shorter cases should be done first in the list, so they will go home. Early admission should be there, 30 minutes to admit and prepare for the procedure. And if there are shorter surgeries, then 3 to 4 patients should be admitted before starting the first case, so there will be no delay. There is electronic scheduling system is available, which will help the busy ophthalmologist or any surgeon to schedule their cases. And these are the scheduling platform which is available for iOS and Androids. So IoT medical devices are there now, AI is there. So end-to-end patient portal to facilitate effective communication between patient and healthcare organization. Start from the time of appointment till the recovery. Send reminders to the patients before their admission. And this will improve patient activation in their own care. So it reduces the OR delay with limited staff. You can post online pre-operative and post-operative surgical guidelines. Less verbal exchange is there, so less time is involved. And save healthcare staff vital time to do other productive work. You can also see the doctor's utilization of allotted time. So there are integrated OR time app also, which will put just like there, that total allotted time and remaining time, which will make staff more aware and what to be done if there is delay. Open communication with staff is also important. Weekly team meeting should be done. One should not be the total boss to share the vital information about any issue that arises. Ask your staff to document and communicate the problem and turn feedback into actions. So to conclude, to have an effective OR, one should need a visionary leader, competent surgeon and anesthesiologist, a well-trained staff, and now is time to incorporate web-based services, and one should learn from experience because each and every place the problems will be different, so one cannot say that it should be done like this or it should be done like that. So it should be tailor-made, and regular feedback from staff, from anesthetists, and from the patient should be taken to have a effective OR management. Thank you. So, we have how many minutes? 2 minutes. Dr. Arshad, do you want to tell something about ultrasound guided block? Peribulbar? Okay. So, anyone else, if want to ask something? So, I will say that it is said that ergonomics of the OT is very important, but it is not every place, because in our place we have OTs not adjacent but in front. So in one OT, the table is on the surgeon is on the left side, assistant is on the left side, anesthesia machine is on the left side, but in another OT, it is on the other side. So it should be tailor-made. It is well said then done. Surgeon should see, and it should be with the anesthetist and surgeon's collaboration to have a better outcome. I will ask Dr. Tanveer, did you see any phenylephrine-induced pulmonary edema? Okay. So, anyone else want to contribute? Dr. Shalini? So, Dr. Suman said about dexmedetomidine intranasal. So, I was reading about the efficiency in the OR. So, I saw one thing that one surgeon said that they had shifted to sublingual medication to reduce the time. So, sublingual is very, dexmedetomidine is tasteless. So, the patient acceptability for sublingual dexmedetomidine was better than intranasal, and then they shifted it to those. So, the one problem with dexmedetomidine is that many times if you are using the adequate dose, it leads to sedation and the discharge of the patient is delayed.
We've been using Dexmed for almost a decade now at Netradama. We started off with loading dose and an IV titrated doses of say 0.25 micrograms per kg, and we went on to maintenance of 0.25 mics. Then we got the confidence to shift to intranasal Dexmed after having quite a bit of confidence. Even in beta block patients were very comfortable. So now intranasal Dexmed we are also using at 0.5 mics to control white coat hypertension, so that we can allow the ophthalmologist to give the block and not cancel the case on table. So not only for sedation, even a smaller dose is being used for reducing blood pressure on table.
Okay.
But it requires about 20 minutes to have onset of action, but it's amazing that we do not cancel any cases anymore. And like you said, ma'am, intranasal Dexmed we are using as pre-medication for children too. We do not have experience with sublingual as of now. So I'm assuming the absorption may not be very predictable in a sublingual route. I'm yet to get experience in this.
Okay, thank you so much.
It almost has the same bioavailability as intranasal, more than 90%. Unlike oral, which has a bioavailability of only 75% or so.